Good morning, everyone. I'm Patrick Pfau from the Division of Gastroenterology, and I'm going to be the person introducing our speaker today and moderating our questions. Our speaker today is Dr. Rebecca Minter, as most of you know, from Department of Surgery here at UW. She her education background, she graduated magna cum laude from UC Denver for undergraduate, got her MD and her MBA from the University of Texas Southwestern, did her surgical residency and research fellowship at the University of Florida. She began her academic career at the University of Michigan, where she was an assistant and associate professor. Of note, she was division chief of hepatobiliary surgery and GI surgery there. And as it applies to this talk, she was also the general surgery residency program director and vice chair of education during her time at Michigan. Then she became full professor at UT Southwestern and also chief of their hepatobiliary surgery. And as most of you know, Dr. Minter came here to UW in 2018 as the AR Curreri professor and chair of surgery. Since then, she has greatly grown the clinical programs, the number of faculty, and the research program of the Department of Surgery here at UW. On a side note, she's also been very kind to the Division of Gastroenterology. She has multiple awards, both societal and institutional, throughout her career. She serves on multiple UW committees, too many to count, multiple national committees. Has over 200 national and international talks, over 150 publications and book chapters, and really two main clinical and research interests. The first being surgical oncology and care of the GI cancer patient. And the second really is the topic of today's talk, is medical and surgical education. And the title of our talk, which is I think quite an interesting title, is Would I Trust You to Be My Surgeon? How do I know? And Rebecca, it's time you take over, please.
Thanks so much, Pat, for that kind of introduction. And when Pat initially asked me to do this grand rounds, it was going to be about the pancreas. And as much as I love the pancreas, not everyone feels that way about the pancreas. So I thought I would try to pick a topic that's relevant to everyone here, and really am deeply grateful for all the tremendous colleagues we have in the Department of Medicine across all of the divisions, and the great care that you all provide in collaboration with the folks in my department for our mutual patients. But whether you're a patient or you are recommending a surgeon to your patients, this hopefully will be relevant to you. So I have no specific conflicts to disclose. I am the rising chair for the American Board of Surgery Board of Directors, and so my talk will definitely relate to some of the work that's happening there, as the American Board of Surgery is really leading a lot of work in this space, but my views expressed here are my own and do not represent any official perspectives of the ABS. I will say, though, will also disclose I'm super excited about where things are heading, and as we'll talk a little bit about, I think, when you embark on an academic career in academic medicine and you have things that you're passionate about that you want to see forward, a lot of times things can sort of move at a snail's pace, whatever that area of research might be. But it's been super exciting the last several years to really see things translating in a way that I think will have impact during the course of my lifetime and career. So with that in mind, I always like to start off this talk as I'm quickly becoming the senior person in the room, which is hard for me to say, but I think it's good as I look back on my career and look ahead to what I hope to achieve in the rest of my career. I think there are these threads that often are not visible to us at the beginning. And I started my career off with a very traditional sort of basic science path. I had a KO8 and studying sepsis and liver failure and liver disease, and did a lot of dynamic Bayesian analysis, which ironically now becomes relevant to the work I'm doing in surgical education, but really was on a very different path. Loved my basic science work, but what I found kept keeping me up at night, and the things as I got busier and busier, as I added more things onto my plate, that really I was deeply passionate about and was willing to stay up late or work on the weekends on was really this idea of how do we improve our paradigm for surgical training. And so I think the advice I would have is that, our careers are long, and you have to really find something that you're passionate about, and then, really roll up your sleeves and lean into it. And I think a lot of times, and I particularly find this true in scholarly work in the medical education space, because frankly, scholarly work in medical education is quite new. You have to be really clear about the problem you're trying to solve and make sure it's a big enough problem to carry you through your career. I think a lot of times folks come to me and say, "Oh, I'm gonna do this survey or I'm gonna do this thing." And I'm like, "Well, what problem are you trying to solve?" Or I'll have a faculty member say, "I've got to get my goal is to get the R01." I'm like, "No, your goal is to cure cancer. The R01 is a means to an end." So what's the problem you're trying to solve? And then again, make sure it's big enough. It's gonna have a long roadmap and you're gonna chunk it and figure out how you're gonna get there. But it needs to be a really, audacious big problem that you want to work on to sustain you over time. And then how do you move it forward? You find really smart people and you listen to their ideas. So, this is true for whatever kind of science or scholarly work you pursue or whatever problems you decide to work on. What you think is going to be the answer usually won't be, and it's going to be a very curvy road. But the more people you can engage and the more you can collaborate, iterate, and then translate to the next step, you'll make progress. And then you'll look back in 20 years and be shocked at how much progress you've made. And it will feel overwhelming. So again, pick a really big problem, but then work it backwards into steps and chunks. And then it's always about implementation. And as a chair, I say this all the time, like people come with great ideas. It's all about the change management. It's all about the implementation and the implementation science. Be persistent, but flexible. Again, it can't be your way or the highway. And I think this second concept can be really relevant to the story I'll share with you today. You don't always have to be the first mover. What does that mean? You don't always have to be the person who brings the idea first. Sometimes being the fast follower and building on what others have done, that gets back to listening to smart people and building on their ideas. Both of those paths have great promise. And then you have to really be resilient. Never been more true than the moment in time we're in right now for those who have funding for their research. How do you adapt? How do you respond? How do you move forward? If you hit a wall, how do you go around it? And so I think this is relevant no matter what you pursue in academic medicine, but on the day-to-day, it can be easy to forget that. So what was the problem I was passionate about? I would say it really boiled down into really this kind of these four quadrants, if you will. If we think about competency-based training, which was the big sort of thing I was interested in, we have a very time-based, I think we produce tremendously fantastic physicians and surgeons in the United States, but our system hasn't changed a lot and healthcare has changed massively around us. So, we had a very numbers and time-based system. You do this many operations, you do this many weeks of service, this many years of training, and poof, you're, a competent surgeon. And for anyone who has given boards, you will know that in this country, we produce amazing doctors, but they're very heterogeneous. And so when I give the oral boards, I can go find out who these people are afterwards. And there will be people who I'm like, I need to go see where that person is because I want to hire them someday. And there will be people where I say, gosh, I hope I don't get sick in the town where that person's practicing because they pass, but just barely. And I don't see that as the fault of the individual. I see that as a fault of the training system because someone should not dedicate, in our case, 7 years to their residency training program, as we have 2 years of academic development time, or 5 years, as the case may be for our rural track residents. Someone should not graduate from a program and not be ready. We are failing if that's the case. So when I boiled that problem down, really in terms of where we were in surgical training, I think we were all very dissatisfied with the assessment systems. We had created this competency framework at the ACGME, which made sense conceptually, but it was very artificial. And what happened was everyone just rewrote their goals and objectives in the language of the competencies, right? And nobody knew what systems-based practice was or problem-based learning and improvement. And we would sit in the clinical competency committee and say, we're supposed to assess someone and their well-being, and we'd be like, oh, well, they work out, so they must be really well. So we really didn't move the needle as we hoped. Milestones were a little bit better, and I think the best thing that came out of the competency initiative through the ACGME was really the clinical competency committees, the idea of bringing multiple points of assessment together and discussing, but we have still had a long way to go. And it was really challenging for our faculty to, again, provide useful feedback to our trainees in this competency framework. We just made the end of rotation evaluations twice as long so we could use the right words, and it really didn't move us forward at all. If anything, I'd say it may have moved us backwards. There has been tremendous lack of transparency for increasing autonomy. And as Dr. Fowl said, I did my medical school at UT Southwestern at Parkland Memorial Hospital. I didn't see a faculty member in the OR there ever, frankly, or very rarely. It was all residents. I was enamored by how amazing the residents were, which they were. And but there was patient harm in that model. There was, if I sat there thinking there's no way, I'm going to be safe to be operating on someone by myself, by PGY 3 year. That's not what I would want as a patient. But they had a lot of confidence and they learned a lot in terms of being ready for independent practice because they had that experience during training. We shifted the safety concern to having too much supervision and not having any opportunity for that increased autonomy in our training paradigms. Lots of reasons for that we don't have to go into today that I think we all know. But if you turn someone out into practice that's never led the operation from the left side of the table and never had that opportunity to figure out, you don't know what you don't know until you peel back all those layers of support, that should happen during the progression of training so that you can turn to the person to your left and say, okay, why is this so hard now? And figure that out while you still have that supervision, but backed up a couple of steps. And we completely have lacked that in our training models. And I already spoke to this issue of producing a heterogeneous product. And if who we serve as the American Board of Surgery is the public and patients, we should be able to say that every board certified surgeon meets a certain bar with great confidence. Doesn't mean it's the ceiling, it's the floor, but everybody should be able to do a certain set of things independently and competently, and we should feel really good about that. So this was sort of the framing of the problem that I was grappling with, really going all the way back to residency. And I think, for anyone who does medical education, it can often feel like it's the flavor of the month, that, oh, here's the next big thing that you have to do. Poor program director. I was actually not the program director, I was associate program director, because in that role, I figured out I didn't want to be the program director because it's a really, really hard job. And I wanted to do more of the strategy and thinking and less of some of the operational things that needed to happen as a program director who I think have a special place in heaven for all the incredible work that they do. But this has not been the flavor of the month, actually, for the American Board of Surgery and the surgical community at large. It has been, again, a thinking about this problem for a really long time. Really, this is 2 decades worth of work to bring us to where we are today. And I'm not going to talk about every single node here, but I do want to call out a few. Going all the way back to 2005, there was the community of surgery came together, the ASA's American Surgical Association, and published this blue ribbon report on surgical training. It touched on many of the issues I just talked about, put forth a number of recommendations, but they sort of went into the ether, right? Nobody sort of owned them, who was going to move them forward. They talked about a lot of different things, but competency-based training was among them. The milestones were then published in 2012, again, not that long ago, 13 years ago, where we finally had something to go under those competencies to say, what do we mean by systems-based practice in surgery? What do we mean in the patient care medical knowledge competencies? And really, 2 years later, the American Board of Surgery really engaged in the conversation around residency reform. And there was a lot of pushback around this, around kind of stay in your lane boards. That's not your job. That's ACGME's job. But the American Board of Surgery felt really strongly it was their job to engage in this conversation, because at the end of the day, they're the ones telling the public that this surgeon is safe. And if the first time they intersect with that person as at the end of their training, when again, someone's committed, years and years and years to their training, and then there's a problem, we're not in a position to fix that problem. So they felt like it was their lane. Around 2015, Canada, the Royal College of Physicians and Surgeons, really under the leadership of Richard Resnick, engaged in competency based training at the level of the country. And so competency by design in Canada was rolled out. It's a little more straightforward in Canada because their ACGME board is all under the Royal College of Physician Surgeons, so it's totally vertically integrated. And they were able to say, we are going to do this. The ABS committed to CBME around the same time, and the story in Canada will become relevant to this concept of first mover versus fast follower. The Netherlands actually are the furthest ahead in terms of having really an integrated competency-based model from UME all the way to maintenance of certification. And they had really engaged in this concept of EPAs, which I will be talking about today, which are entrustable professional activities. And so the ABS flew to the Netherlands, took a whole group of folks there to learn more about that and how that was working. Now, the Netherlands is a very small country and much less complex than the United States, but still was really useful to see how that had been rolled out at the level of a country. And so we really at that point committed to moving forward with EPAs, and I'll tell more of that story to come, and launched as a requirement in 2023, the requirement that all entering residents in 2023 will have to submit to the American Board of Surgery their portfolio of competency-based assessments to be eligible to sit for their boards. And so that sort of brings us to today. So I've been engaged in research in this space, going back a long ways, but around entrustment going back probably to around 2012 to 2015, where we really, and it was actually a resident who brought this concept of, he was doing a surgical education research fellowship, and I was his mentor, and he's like, I want to do this project on EPAs. And that was probably in 2010. I'm like, the Environmental Protection Agency has nothing to do with surgical education. And so then he educated me about what they were, and I was like, okay, I'm not sure that's going anywhere. And so that was Nick Tiemann, who's now a cardiothoracic faculty member in Colorado. And so Nick brought this, so that was my first sort of introduction to EPAs, but this concept of entrustment I really, really connected with, because it bridged a big gap for me in terms of what was missing. And it did so because it really recognize that we function in a very high stakes environment in the operating room, in medicine in general, in the operating room, like, very high stakes, very high stress. But we provide this progressive autonomy to residents, but with close supervision by faculty. And progressive entrustment would suggest that the first part doesn't change, it's a high stakes environment, but that we give that progressive autonomy, it's trusted to the residents, and the faculty supervision is still there. That I don't believe that old days were the good old days. I think there was harm that happened there in a different sort of way, but we've got to peel back that supervision to make sure they're ready for practice with the faculty being there. And that requires a tremendous amount of faculty and resident development. In the early part of my career in this space, we really focused on faculty and resident development and developed a tool called OpTrust, which I'm not talking about today, to really train people to do that, because it's really, really hard. And for anyone who does procedures, they know this. It's really, really hard as a faculty member to stand there and watch someone struggle, but everyone needs to have some safe struggle to get over that hump. It's really hard not to fix the retractor if it's in the wrong place. Patient's not going to die if the retractor is in the wrong place and someone struggles for a few minutes before you tell them why. I guarantee you they get the retractor set up right the next time. But it's hard to do that, and it requires faculty development, especially with all the time pressures and things that we're under as faculty. The best definition of trust, I think, is this one, which is acceptable uncertainty. So for anyone who has had a teenager who's learned to drive, this is my son. He's 17 now, but when he turned 16 and he so badly wanted this car, and so we were at the used car dealership, And we're about to, hand over the keys, right? And to do that, and I feel this is such a great parallel for surgeons in training, or again, any doctor in training, we had to have acceptable uncertainty that he'd driven enough with us, and that we thought he was going to be safe and likely come home safe and not injure someone else, that he was a responsible kid, that he was going to do what said he was going to do, and show up in the right way. I don't have absolute certainty of all those things, and he in fact has had a speeding ticket, but you have to sort of get to a place where you trust them enough to turn over more independence. And so I think that for me is this concept of trust that anchors all of this work that is super important. Ali Tenkate is a PhD faculty. He's not a surgeon or a physician. He's at the University of Utrecht, but he's the one who really has been the thought leader in this space and developed the concept of EPAs in the Netherlands. And this came to Ali because it was actually the chief nursing officer in the ICU there was talking with him, and she said, "Ollie, like, these kids are brilliant. They're way smarter than they've ever been, but sometimes they miss the forest for the trees." And she said, "I think we're doing this to them because we have all these checklists. We're supposed to check them off on, can they put in the central line? Do they prep right? Do they do this?" She's like, "But they don't know who needs a central line or how to manage complications, etc." And we had become very, we like this concept of everything being very objective, and we're going to drill it down to all these checklists. But we were, again, missing this higher level big picture. And Ali describes this concept of trust in 4 conditions, which is very relevant. Again, I mentioned some of them in talking about my son, but this is what our end of rotation evaluation looks like now with EPAs. It says nothing about the competencies because we get the competencies through the EPAs, which I'll show you, but it focuses on these things. And in order to trust, you have to have enough exposure with someone, first of all, but you have to know what their ability is. So, could my son drive? Had he done all of, the driving with us? What can he do? What can't he do? You have to have integrity. And this really comes through in training as honesty and truthfulness. If a resident calls me from the bedside and says the patient's sick, they better be at the bedside, right? Because if I find out they're not, and they're calling me from home and they're just conveying what the intern told them, I'm going to have some major trust issues because they weren't truthful. Are they reliable? Do they show up predictably and consistently? Are they trying their hardest? And this humility piece is really critical, because you can have people, speaking for surgeons now, I'm sure this is true for all physicians, you can have people who are really talented, super smart, have incredible technical abilities, but if they do not know their boundaries, they do not know when to call for help, they don't tell you when your patient got sick, they just manage it for you, that is not entrustable. So the final sort of piece of being fully entrustable, which comes through in our clinical competency committee, is this concept of, do you know your boundaries? Because when we all go into practice, we all need help. We all call our partners, we all need help. And if you have someone who's not willing or able to do that, they are not safe and they're not fully entrustable. So this is kind of that frame of entrustment that underpins. So then he took this concept and said, let's, faculty don't know what the systems-based practice and practice-based learning improvement are, yet we're asking them to assess a learner in those categories or buckets. And the way I like to think of this is, I every day take care of patients with pancreas cancer, and same could be true for my colleagues who are endocrine surgeons. They take care of patients with parathyroid disease, thyroid disease, etc. And where we're assessing our trainees is what this concept of workplace-based assessment, and that's what EPAs are defined to do. They are not going to assess everything someone needs to know, but they are going to define the core work of a surgeon, these activities and trustable professional activities, which represent the core work of a surgeon. And the reason that they work so much better, in my opinion, is it describes this discrete element of surgical care that our faculty can actually relate to. So if you were to ask me, Rebecca, do you trust Jane to evaluate and manage a patient with pancreatic cancer? I will immediately conceptualize and say, well, I trust her to do the preoperative phase of care. She can read the images. She can come up with an operative plan. She knows how to work up the patient. Not yet fully entrustable in the operating room, partially entrustable postoperatively, can manage some postoperative complications, not all, et cetera, et cetera. I immediately can do that. That touches all the competencies: patient care, medical knowledge, communication, all of them. I don't have to break it down. I'm going to give much better feedback around that rolled up sort of professional activity that I do every single day. I know what I'm looking for. I can conceptualize it. It starts with the end in mind. And so and again, this is a floor, not a ceiling. So it's a saying that everybody will be able to be entrustable to do these things. What is that core for your profession? Um, what what do you expect all graduating residents or fellows to be able to do independently? And that's what we're then telling the public. And I like to call attention to this figure at the bottom. And I know, most of you are not surgeons here, but this in the operating room, we all like to say it's factually like I could do half of a Whipple with a suction device, and the trainee across the table probably wouldn't even realize they're not doing the case. And when we had started our work on OpTrust at the University of Michigan, we did a lot of this work with residents, and we had this was our symbol for our work, and it was handing over the scalpel. And the residents who were the model hands here, or the hand models here, I should say, were like, absolutely not. You all don't trust us when you give us the scalpel. You give the medical student the scalpel. You trust us when you give us the right angle because you use the right angle to do all of the dissection. And we were like, oh, you know that. And it's absolutely true. When you turn over the right angle and say, okay, do the dissection, they have to know the planes, they have to know how to stay in trouble, don't stick the right angle in the portal vein, et cetera, et cetera, et cetera. And that is that demonstration of trust. And this concept that this is all anchored in trust is really helpful. If you give someone a Likert scale end of rotation evaluation to fill out, it is very impersonal. If you say, would you trust this trainee to do this for your friend or for yourself or your family member, it really changes the feedback that you give. So I'm going to move more quickly here with that background. This concept of first mover, fast follower, I think is really helpful because we followed Canada. Canada have been the thought leaders and brilliant in this space. They have struggled with implementation, and we have learned a lot. The mouse thing is a little morbid, sorry. But we have learned a lot from them and been able to avoid a lot of the mistakes around implementation, and which have allowed us to move forward much further and much more easily than they have in Canada. And so again, learn from others. Learn from what has worked and not worked in whatever your sphere of research is, and then take that as your next jumping off place as you go forward. We started a pilot. It's very hard for people to agree what is general surgery. And so rather than getting stuck, we did a pilot through the American Board of Surgery focusing on these 5 conditions because everyone could agree that these 5 conditions reflected general surgery, whatever your opinion is of what is general surgery in this era of specialization. And we developed these EPAs, these professional activities for those 5 conditions. And the process for developing EPAs is long and extensive, which I won't go into right now, but it starts with defining what are the functions of that activity or that task, and then the milestones are mapped underneath, but I say the faculty don't have to know what's under the hood. They don't have to know which milestones are there, and I'll show you why. And then we describe what are the behaviors for the levels of entrustment that you expect to see for evaluating and managing a patient with gallbladder disease, for example. We initially had 5 levels of entrustment. We now have these 4, and you progress from limited participation to practice ready. And there are descriptive behavioral anchors for each level of entrustment as they proceed. What is the entrustment scale not? I think what started to happen with EPAs is what happened with our competency initiative, which was people just started relabeling everything in EPA. They just took their objectives and they relabeled everything as an EPA rather than as a milestone. And we really had to work hard to stop that at a national level because EPAs are not a generic Likert scale. They have behavioral anchors. They are a lumping, not a splitting exercise. They are rolling up and saying, what does this trainee look like? What do they look most like? Do they look most like this set of bullet points or the next set of bullet points? And the idea is that it's a fallacy, this idea that checklists are very objective, et cetera. They're not. We have Hawk assessors, Dove assessors, patients are different, et cetera. This is really trying to create a shared mental model for what does a trainee at indirect supervision look like. There will be a lot of difference of opinion around that, but the idea is you're doing this every single time you're interacting with a trainee. It takes a very brief amount of time, and you'll see how the data comes together to tell a story over time. EPAs are also not a checklist. So it is, again, this higher level activity, evaluate and manage a patient with gallbladder disease. It's not insert the trocars, find the critical view. That it's not a checklist sort of assessment. It's a higher level construct. So the pilot rolled out over 2 years. The goal of our pilot was just to learn about implementation, to learn. We had programs from all over the country, small programs, community programs, big academic programs, programs with people like me who were really supportive as chairs, people who had unengaged chairs, and just to really try to deeply understand what was going to be critical for implementation at a higher level. At the conclusion of that pilot, we learned a lot, and we developed these 18 EPAs. So this is what represents the core of general surgery. The first 5 are the ones in gray, and these are the 18 EPAs. This is not everything a graduating resident needs to know. EPAs require that you must be able to assess that EPA in multiple contexts, in multiple conditions, in multiple contexts with multiple assessors, multiple times. So you can imagine emergency airway is a critical skill a graduating general surgeon needs. We're not going to do that as an EPA. That's going to have to happen in the SEM center, because if we have every resident doing multiple emergency airways, we have a different problem. But these other things that represent the core of what we do in general surgery should be able to be assessed and evaluated multiple times. In multiple conditions. We don't know. We're gathering that data now, and that's informing also the state of training across the country. So what needs to change? Not as much as you would think. This really sort of codifies what we do today already. The EPA microassessments that I'll show you really are focused on the ad hoc entrustment decisions we all make every single day with trainees as faculty. So this is, I get called in the middle of the night. They say, Dr. Mitcher, your patient's here in the ED. They had a Whipple 2 weeks ago. This is happening, this is happening, this is happening. Here's my plan. I immediately, without even thinking about it, I say, do I know this trainee? I go back to those 4 conditions of trust. Have they told me a good story in the past? Does their story make sense? Does it sound right based on what I know of the patient? Et cetera, et cetera, et cetera. And I immediately, within seconds, make 1 of 3 decisions. I say, that plan sounds great. Thanks so much for letting me know. Or I say, that plan sounds pretty good. These minor modifications. Or I'm like, I'll be there in 10 minutes. I'm getting out of bed and driving to the ED. And we do that all the time. We make these ad hoc entrustment decisions, and all we're doing now is laying a framework on top of those ad hoc entrustment decisions to be able to capture that data in a way that provides the trainees with a lot more feedback and our competency committees with a lot more feedback. So that's what really is new and improved, is bringing that data from those ad hoc entrustment decisions together in a way it's easy to collect for our faculty, but tells us a much better story over time and gives us much better feedback for our trainees. It also gives the trainee a roadmap for what they're supposed to do and how they're supposed to show up, rather than every time they show up with a new attending, trying to guess what they want them to know. It really sort of says, if you want to progress an entrustment for this particular condition, here are the things that you need to focus on. And so that blueprint has been a huge move forward with developing these EPAs. I will say our institution, and I'll show you some examples of that, really focused on this second piece, which is where I would say we are struggling a little bit right now, because the American Board of Surgery is having to change platforms and things, because these enabling analytics are critical to success. We developed an app here for data collection, and more importantly, an analytic platform during that pilot from 2018 to 20 that we've continued to use along with another institution and some fellowships, that has really, I think, allowed us to be a lot more successful than some other places. I think we'll get there with all the other places, but this is a key piece. So just to show you what this looks like, I'm going to start these videos and play them in succession here while I'm talking. If I can get them to work. So this is the app we developed, CIFA. And so it takes really seconds to do this. It can be initiated by the faculty member or the trainee. At the end of a case, I always initiate because I'm walking down the hall while they're finishing up the case. In this example, the resident's initiating. You can pick which phases of care they were involved in. And then you just swipe back and forth. You look at the descriptions and you decide which level they looked the most like. You select that level. This is the resident filling out. The resident has to do this as well. So then they're going to do their self-assessment. So they'll type in their self-assessment. You can dictate or type. Almost everyone dictates what their assessment is here, and you can see this is as long as it takes. The trainee then submits it, and it's going to come pop over here to this middle panel to the faculty member. They'll get a notification that they have an assessment to complete. They open it up. They have 72 hours to do this. They get an email reminder too if they forget, and they do their assessment. They can't see what the resident said at this point, but they do their assessment. They dictate their feedback in the same way. And then, and I always look, you can see here this little green means that both people have assessed. So then I can see what the trainee said. I always look to see what the trainee said. And this instance, you can see we both said the same thing. So it means that trainee has pretty good self-awareness, picked the same level, and picked up on some of the same things that I did in that case. And that is super important. All of this takes literally less than 2 minutes, and it's very intuitive. What we learned through the pilot, and none of this is rocket science, but what's critical though to maintain engagement around that is that those assessments can't go into a black hole. They're useful in the moment to look and see what someone said, but if you don't use that data to move the trainee forward, engagement drops off. And so those micro assessments, those ad hoc formative micro assessments have to roll up to tell a higher story. And there are different stakeholders involved in this, and you have to consider what's valuable to each stakeholder group and develop analytics that support that behavior. Obviously, leadership is important, and we've built this in multiple ways into our department to get engagement, which I'll highlight. So these are the 4 stakeholder groups. I'm going to just show you kind of how we engage with them. So residents, faculty, program administration, and the CCC. So this is the application platform that the ABS is using today for general surgery, and works similarly to what I showed you. And in our app, which is critical, formative assessment is required. You cannot submit a micro assessment without giving that feedback, because it's the feedback that is the most important to the trainee, not which level of entrustment you pick. And we really have had some of the feedback, of course, is better than others, but we don't have people who like put a period or something to get out of the app and skip it. So having that feedback every time is critical, and especially now with some of the large language models, our ability to even like distill that down into the final sort of qualitative feedback for the CCC is really, really powerful. So the feedback to the trainee is critical. So what does this then look like? I'm just going to use this is real data. One trainee is an example here of what comes for what's visible to the resident. And we're going to talk some about learning curves because there's some really interesting data in here. But this is a trainee. The gap in the middle is when they stepped away for their academic development time. The red dots are the faculty assessment. And I'm going to draw your attention to this. I'm going to show you this data again in a minute. In this instance up here, on the pre-op or non-operative phase of care for gallbladder disease, and we always get a lot more data for OR, you can imagine. The faculty are assessing her at practice ready. She's assessing herself lower at indirect supervision, which is the blue dots. Down here, you can see there was overlap or the trainee under assessing compared to the red dots in the faculty, and then still maintaining the resident under assessing. This will become relevant to something we've really been able to show in these data comparing male and female trainees. But you can look to see here that if we were to draw a line here, and this is PGY 3 through 5 year, moving up to practice ready, if you just look at the red dots, this trainee is under assessing themselves. Summative data here, lots of assessments, 51 from the trainee, 42 matching from the faculty. So if a trainee is preparing for a case, they can hover on one of these dots from their recent case and see what the faculty member said, just to refresh themselves on what they need to work on. So this is available to them in their platform. This is small, and I don't expect to be able to read it, but this is probably more valuable for the trainee, and we're working on that higher level roll-up that will be built right into the app. But you can see here the entrustment level 4, practice ready, 3s, et cetera, with this being the most recent data at the top. And you can, again, quickly look at these comments and you'll see the themes, around using both hands or what they need to focus on for this case. And again, this is the best way to prepare for that next case. They can then go to that next case and say, I would like to work on this specific thing. Oh, by the way, I've done, I have 50 assessments from, 30 of your closest friends who are other faculty. So you don't need to show me how you like to do this operation and have me watch this first time, which is what can happen. So we can use this as a proxy for their experience. We can help drive them as the learner who's bringing the focus for the case, but also make the faculty feel more comfortable. Oh, like Dr. So-and-so has actually done a lot of these. I need to give them more autonomy on this operation, even though I haven't personally done a lot with them yet. The faculty lens. The faculty love, 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 even more than the residents, just this intuitive micro-assessment approach. It's so much easier. We all hate the end of rotation evaluations, and we've really shortened that end of rotation evaluation. And they have access to that same information, but let's be honest, it's not the faculty member who's dying to do the case, it's the resident. So we don't expect the faculty members to go and look at those things. We expect the resident to take the lead on bringing that information to the faculty to say, look, I've done 50 of these cases and your peers think I'm at practice ready. Can I please, be on the left side of the table, have more autonomy in this case? Here's what I'm still trying to work on. But the faculty can see the same things that the residents can see. So this is an example from UAB's pilot and the app that they developed. And this is something we're building into our app, which is that, again, that allowing to trust. So being able to say, this is for a fellow, an endocrine surgery fellow, intraoperative benign thyroid disease, 40 assessments, practice ready from your colleagues. And being able to show that app and saying, here, look, here's where I am for this EPA, and making it easier to use those analytics to create as that proxy to create more trust, even if you haven't had personal interactions with that trainee before. And it's one of the struggles of our residency evolution over time is we have a lot more faculty and the residents are relatively fixed. So we don't have that same relationship in terms of just knowing what someone can do. The Clinical Competency Committee is really the biggest user of these rolled up analytics. So this is just showing you the first 5, an example of the first 5, because we have the most data on those. But we have this now in our CCC for all 18 EPAs. Again, you can see this high level picture looking at all of them. You get this summary assessment count here in terms of the different EPAs. And down here, it has a summation. If you scroll down, it'll have with the confidence intervals, the entrustment levels. So it really provides the CCC with that higher level picture of how they're doing. And the CCC will make a determination every 6 months of how they're progressing and what entrustment level they are at. And then that's that summative information we can roll back into the app that I was just showing you. Again, if you have like an outlier dot, you can, we all have hawks and doves, you can highlight it and see what the feedback is, or if it was a really tough case, right? This case was challenging due to moderate adhesions, et cetera. So that would explain a lower level of entrustment versus the other dots. And so it's a really easy to use, useful platform. As you can see over here, you can filter to get to the different EPAs that you want to look at. And again, this construct of EPAs are used across all disciplines. Internal medicine and pediatrics actually were the leader in this space in the US. So I'm showing you surgical EPAs, but this is a construct that is broadly applicable. This, again, if we want to drill down then and just look at appendicitis, this will then show you all the comments. And importantly here for our program directors and program administrators, they still have to submit to the ACGME the milestone reporting. And as I mentioned earlier, the milestones are all mapped under the EPAs. And so we will be able to, and I'll show you how it looks, we'll be able to give you that milestone report that's extrapolated from the EPAs. I wanted to just mention this because one of our chief residents, the one that I just showed you her earlier data, and I'm going to show you 2 different sets of data, gave this incredible Grand Rounds Chief talk this year on how her confidence was really negatively impacted by a really unuseful and very negative piece of feedback, very kind of in her PGY2 year, that made her believe like she couldn't be a surgeon. And she carried that with her for a couple of years before she finally broke out of it. And what we've been able to see in this data now with like over 10,000 data points, and it's very consistent at every PGY level, is that our female trainees consistently underestimate their abilities. So this was a different trainee, also a female trainee who graduated a few years ago, but who was outstanding. And you can see her blue dots are always down here. She never rated herself as practice ready, but you can see the faculty all moved her all the way up to all the way to can teach others, which is this highest level. But her blue dots were always down here. This is significant at every PGY level. The thing I'll tell you, our male trainees are not overestimating, they're just much better self-assessors, and their dots tend to be right on top of each other, which is good because if you lack confidence, you don't want to be overconfident. It's a problem if your dots are above the faculty, but if your dots are on top, that's good because you know what you need to work on and you are an accurate self-assessor. If you lack confidence, it can be driving, it can push you to be better, but it can also be debilitating. And so how we give feedback to our trainees and our female trainees in particular, if we're seeing this kind of a pattern, is really important. And this data should be informed by how the CCC feeds back data. This is that resident who gave the grand rounds this year on really having lost her confidence. And you can see she carried it to the OR. She was really stuck at this level 3 indirect supervision and not breaking out into this higher level until she finally did. She didn't rate herself any higher, but she finally was showing up in a way in the operating room and demonstrating more confidence that the faculty felt like she was moving into that practice ready level. And so I think, if you see someone who's stuck, we need to ask, why are they stuck? And now we have the data to see that in real time and help people earlier rather than waiting until they leave the field, which is what unfortunately can happen in these circumstances. Or they get labeled and then they hide from the operating room because they're afraid, or the faculty don't let them do anything because they're a bad, they can't operate. And so this data will help us prevent all of those terrible things from happening. And sometimes people do need to move on, and that's the right answer, but hopefully they can move on after their PGY3 a year rather than spending, 5+ years of their life and then having to pivot and figure out what they're going to do, which is a terrible situation. Lastly, program administration. As I mentioned, you still have to submit this milestone report. And so as you can see over here, this is for patient care 1 milestone. This is where they're mapped into all the different EPAs that we collect. And you can see we can get a lot of data for a lot of these. So this is produced before the CCC for the program administrator, a coordinator, and director. And here, this is a pretty darn good assessment of the patient care 2 milestone for us. There's 60 assessments from 25 faculty. That's way better than anything we've ever had before to base our milestones assessment on, versus these 2 milestones, professionalism 1 and PC4, we actually don't assess very well with our EPAs, and that's where we'll need other assessments and evaluations, that end of rotation evaluation that really looks at those other conditions of trust, or professionalism 1, which ties to completion of duties and tasks. We have other assessments that we do for those. But this gives you a great starting point for submission to the ACGME for your milestones. Again, way better than anything we've had before. So how do you do the change management? We really have done a number of different things. We have this on all of our kiosks. Now you know what it means. These are our top submitters for our faculty and trainees, really trying to drive for kind of friendly competition. We provide data to our divisions each month, and we have set some goals and actually tied this into our education goal for our Y2 portion of our comp plan. But you can just see between 1 month's time where we started providing feedback for our trainees and our faculty in terms of non-response, as well as driving engagement through these different mechanisms. It really made a significant difference. Not expected to read this eye chart, but it's just to show what we did was we mapped the different EPAs to our rotations. So we told the faculty in a given division, you're responsible for these 3 EPAs because this is what you do all the time. You can use any of them, but these are the ones we want you to really focus on so that we could distribute them across all of the different rotations. And then this again is we get our RVU data. We also get our EPA assessment data each month. The division has a goal that they have to hit. My division chairs, this is one of their Y2 goals. And you get this data, and this gets put up at the division meetings. colorectal division are superstars. Everyone's logged into the app, but sometimes this says no, right? And then the division chair can go and say, hey team, you haven't even logged into the app in 90 days. How, you got to do that. So we provide this feedback every month in real time to our divisions. And this is just the data through March of this year. And you can see, again, we have almost 2,500 micro assessments, and this has been very consistent everywhere. It's about 50% will be initiated by trainees, 50% by faculty. It really is that partnership. It can't just be one or the other. And most EPAs are performing well. Severe acute pancreatitis is not, which we anticipated because mostly that's managed by our GI colleagues now, not surgeons, and renal replacement therapy. The reason those two were included were because out in practice and the community, which is where most surgeons practice, those two conditions are things that general surgeons have to be able to help manage with, and we're going to have to just figure out how those perform over time and how that training happens. So just lastly, in closing, I think EPAs really are just a much more relatable assessment framework to get us to that competency-based training. It allows faculty to do what they do well and give feedback that's much more helpful. The milestones are there, but they don't have to know about it. The data has to be used. It has to bring value to all those different stakeholders. If it doesn't, you won't be successful because people are busy, and even though it's only less than 2 minutes, it's 2 minutes that they could do something else with. And we've got to really engage the residents in using the data to drive their own learning. We want them to be in the driver's seat of using that data to move forward, and leveraging the data to do that really does lead to increased engagement and growth over time. So our change management approach for this at a national level has really been one of progressive engagement. There's only 5 programs right now that are not haven't logged any EPAs, which is pretty incredible to me and way more successful than I ever would have guessed at the end of the first year. And they're being used across all levels. They were only required for PGY1s, but we have a tremendous amount of data for every PGY year. So again, seeing the positive impact of automating that behavior, so you just do it every time. So always remember to go back to the why, the 4 quadrants I started with in terms of, the problem I wanted to fix. And so I do think EPAs are better, certainly better than the end of rotation evaluation, which is terrible. The competency framework, this allows us to really operationalize it into a way that makes sense. It creates tremendous, incredible data for that increasing autonomy that, like in the examples I just showed you. And I'm hopeful, we won't know for several years yet to come, but hopefully this will help us produce a less heterogeneous product, because we'll be providing data and much more in real time to identify people who are struggling and help bring them up, or help them move on to something else if it's just not the right fit for them. So thank you for this invitation, and I'm happy to take any questions, and hopefully this was relevant. There was something in here that was relevant for everyone. So thanks so much.
All right, the questions are rolling in, so I'll try to get them as much as we can in the next 9 minutes. One that came out, I'm trying to paraphrase this, is what is really the advantage or difference between EPAs and competencies? Is EPAs just adding more work? How is it linked to competency, or how is it better than using competency to evaluate our trainees?
So I would argue the competencies haven't allowed us to better evaluate our trainees at all. They've just made our evaluation instruments quite long. I think milestones are a little better. The key is to not think of them separately. The competencies and milestones, again, are like under the hood of the EPAs. And if I showed you the structure of an EPA, evaluate and manage a patient with gallbladder cancer, every EPA has 5 to 7 competencies and milestones mapped underneath that EPA. So all of the competencies and milestones are mapped to the EPAs. But other than the clinical competency committee, and frankly, not even them, really the program director and program administrator has to worry about the competencies anymore. So it's really, EPAs are just a way to better operationalize and execute on the competencies and milestones in a way that makes sense to the faculty. The faculty no longer need to know what the competencies are, but they are all accounted for through the EPAs.
And that's not surprising. There's a lot of questions about the specifics of the micro assessments. I get a couple. What do you do when there's significant disparity between the
Mhm.
micro assessments that different faculty are giving to the same resident, say for the same procedure. How do you deal with that?
Yep, great question. And this gets back to as doctors, and I will say surgeons in particular struggle with this. Like we want there to be this like perfect assessment that is the right answer, and that's where all these checklists and things came from. The data actually show that you have to do a minimum of 60 procedural assessments to get to any kind of validity, which is ridiculous, and nobody will do that with these long form OPRS sorts of things. So it was a fallacy to believe that there's some perfect, valid assessment. There are hawks and doves, sick patients, hard patients, there's all sorts of pieces. The idea of this is you get lots of data and you get those scatter plots, right? And you're going to see the curve going up over time. If you only get end of rotation evaluations at the end of a month, you cannot ultimately make that assessment. And so if you see someone who's staying flat, you'll see it. If you're going to see a scatter plot, it's a scatter plot, but you'll be able to draw a line through it. And that goes back to with analytics of being able to hover over the dot. Like if you have everything kind of clustering together, but you have like an outlier, you can look to see why is it an outlier? Is it related to patient being very complex or someone who's particular hawk or a dove? You know that information at the CCC level. So you expect to have the scatter. That's the whole idea. But the idea is, again, with EPAs, you have to be able to assess them multiple times, multiple contexts, multiple assessors. And that's much better than the data we get today, which can often be sort of groupthink at the end of a rotation when nobody has any specific memory anymore of the actual interaction in the clinical setting. So it's meant to be workplace-based assessment. To bring all that microassessment data together, it should be voluminous, and then it tells a story over time.
There's a question, sort of, how does it was timing, when do they get the assessments? And the person putting in context actually is, if a person gets assessed and they did quite poorly, say an appendectomy, and then they're doing a surgery with the same surgeon that afternoon, like a gallbladder surgery, does it affect the relationship of the surgeon and the trainee
Yeah.
and the performance of trainee if they just got a very poor performance and they have to go right back in the OR with that surgeon?
Yep. So this ties back to the resident and faculty development, and this is part of what's happened in Canada and why they have struggled, is that they didn't have the tools to make it easy to do the assessments. They're much too long form. They're not quick, but also they became weaponized where the trainee got to pick and choose who did it, and the faculty were afraid to give honest feedback if it wasn't perfect because it would affect their teaching evaluations and all that. So I think there has to be a lot of resident and faculty development around how do you give a microassessment feedback. And I think the best thing I heard recently is, and this came from the lawyers actually, this was a different talk unrelated to EPAs, but I think it applies, which is take out all the adjectives. So really, here's the idea of EPAs, which I think really has played out in our experience, is you're just describing what you saw, and then you're supposed to tell them what should they do differently next time to get to the next level. So you say, I'm saying you're at direct supervision because I saw this or this, or acts of omission, or you didn't do this and you didn't do that. In order to move to the next level, you need to do this and that. And what I really look for, most importantly, in that interaction, and that's not emotional, that is just, here's what I saw, here's what you need to do differently next time. If you write, oh my God, that's the worst case I've ever done, I don't think you can be a surgeon, well, then yes, that is not useful feedback, and that will not make them show up in a better way in your next case. So it's doing that faculty and resident development. When does it happen? It's a little bit different. Like I usually try to do it right after the case because otherwise I forget. Other people do it at the end of the day. You have 72 hours to complete it. But if you really think about providing objective feedback based on observation and what to do differently next time, it shouldn't create that sort of emotional challenge.
But there's a lot of specific questions, but I'm gonna give you one broad question. We've got 2 minutes left. So you find EPAs as really the core work of a surgeon, and knowing this audience here, can we apply these EPAs to any type of training? To not just, I think it would apply to procedural training, but can this apply to training an internal medicine resident, a infectious disease fellow, to medical training rather than surgical training? Is there a global way you can apply this as well?
Yes, absolutely. And in fact, EPA started with peds and internal medicine. And I can't remember who it was. It was actually the program director at, I think, Cincinnati, who really showed, which I'm hoping we're going to see in surgery too, that they implemented internal medicine EPAs, that it didn't change their attrition of people leaving, but they found the rate, which interestingly is the same as in surgery. I always thought surgery was higher. But they saw them earlier because they had so much more data. So they found the struggling resident earlier at the end of the first year, rather than finding them at the end of the second year or even into the third year. And so EPAs, again, are a constant. In the Netherlands, it's every discipline in medicine, from UME to their maintenance of certification, they use EPAs, from medical school to training to maintenance of certification. It is just workplace-based assessment. You have to do the work to develop the EPAs that are relevant for your field, but it's a concept that applies broadly across.
We'll squeeze in one more question. Dr. Burrows got one in. It's, at the end of your talk, you talked about the difference in gender and how people appraise. Can you do anything about that, or are you doing about how
Yeah.
females appraise their work and they get it in line across both genders?
So I'll tell you what we're doing, but it's a super interesting question to think about, right? Like, I think the first thing is we don't know, like, where should you be, right? Like, if you're an under assessor, but it's not negatively impacting your confidence, there's some data in sport, and we look at performance, right? Sports and things that say that actually drives people to be better the next time because they feel like they're not where they need to be. And do we want to take away that drive? No. But if it becomes debilitating to where their confidence gap, it's a confidence gap where they feel like, this is how women are enculturated in our society, right? Like, you must be modest, we're not going to change all of that. So we really need to bring it back to performance. If it is debilitating and they have like significant imposter syndrome, then we need to help them with that, or they won't move forward, or they'll shy away from things that they think they can't do that they can, et cetera. So what I love in that data I showed you was those were two different trainees, both women. I would say the first one I showed you was doing great, and she actually had a lot of confidence. She just felt like she should never say she's practice ready till she's in practice, but she was ascending and doing great. Pediatric transplant surgeon now, has plenty of confidence. Versus the person who was feeling trapped and was literally like looking in the mirror and saying, I'm a good surgeon before every case, because she was so fearful of going into that because someone had given her really unuseful feedback that said, you're never going to be a surgeon, from a chief resident, actually. So I think that we have to figure out what it means, but it does impact how we give feedback from the CCC. And I have used it as we even do our surgeon evals, where it can be a bit of a, blood in the water for a resident. And I'm like, okay, like, let's back this up and think about like how we're going to share this feedback in a way that they're going to hear it and not actually shut down more.
Is there any, also on the flip side, a way female faculty appraise, and can we do anything about that?
So interestingly, no difference between and that's where we started the study. There was no difference between how our female and male faculty assess our female and male residents. Zero difference. The curves sit right on top of each other. And we have about, in general surgery, about 45% female faculty. So it's a pretty good sample size. But it was the trainees where the self-assessment where we saw the difference. So
we actually could take questions for the next 30 minutes, but I'm sure you have to get to the OR. So Rebecca, thank you very much. And I think it really shows how much in education we can learn from surgeons, and surgeons can learn from medicine, because it's all overlapping, and it's all in need of continued ongoing improvement. So thank you very much. Fantastic talk. And thank you for coming today.
thanks for having me. And